Hello, and welcome to another episode of Plastic Surgery Unfiltered, a podcast at the intersection of healthcare, business, and the beauty industry. I'm joined again by Kristen Rosati, our guest podcaster. How are you today?
I'm doing good, thanks.
We're at lunchtime today instead of our morning.
Mm-hmm.
Today we're talking about the physician shortage, mid-levels, and money.
What a title.
What a title. Where do we want to take it off?
I would say that a friend of mine sent me an article from the New York Times. Apparently, the physician assistant profession has been getting a lot of traction and publication in the New York Times as of late.
Sounds good.
You probably know, but for those of you who aren't aware, physician assistants are going through a kind of identity crisis. And back in 2021, we voted to change our title to physician associates, although that has not been widely adopted by all the states. So there was an article kind of talking about the name change and the implications of that and how people feel about that. So,
are you happy about it?
To be honest with you, I also think it might be a little bit confusing for patients. Mm-hmm. That's my number one concern with it. I think that the PA profession is relatively young, and many patients and the public are finally getting to understand what physician assistants are and what they can do. And I think to have a name change, although I understand what they're trying to do, I have concerns that it may hurt the profession maybe more than it helps, at least in the short term.
I mean, the article talks about how there's 22% of patients already think that physician associates or assistants are physicians. And so that does create a bit of a confusion. Mm-hmm. And the question is, I guess, does it matter?
I mean, listen, I picked PA school and not medical school for a reason. Okay. And this was a long time ago. But I think I could have been a very fine physician.
I think you could have too.
Thank you. Yeah. But I didn't want to do that. Just kind of, like maybe it's just not me to have the number one seat. I'm happy to be like the number two person.
Okay.
So
how would you say, like, I don't know, in a few sentences or maybe a paragraph, like how would you say physician assistants or associates are different than a physician, kind of in your own kind of mind?
I mean, in my own mind, I think that we have some limitations to our scope of practice, but also, and one of the reasons why I did not want to become a physician is that we are not, although we are responsible for people's care, we are not the primary assumer of the responsibility, right? And so as my supervising physician, that is the role that you fulfill for, to allow me to be able to practice medicine. So I think that although I'm not afraid of responsibility, like I never really wanted that ultimate responsibility.
Yeah, I think that, I've mentioned this to you, but there's sort of degrees of healthcare decision making, and those are stratified by titles and level. And so that's why when you start to mix these titles, it gets a little bit confusing. And one of the things that really to me stratifies a mid-level or a physician associate from a physician is the ability to, number one, delegate. So I have the ability to delegate the decision making I make to other individuals, and then bear the liability for that delegation, which is something reserved only for physicians, And I think that this is something so subtle for the common public that it is really hard to understand exactly what weight is borne by that, because it is a systemic implication, it is a financial implication for the system. Our country, which has not had significant tort reform from a medical malpractice component, means that your medical malpractice is pennies compared to what I have to pay in my practice, and that is part of the overhead that goes when I get paid, and as well as sort of the educational liability, which is borne by the physician as well. And I think that, like, I was reading an Reddit blog from a person who was a CRNA, now turned anesthesiologist, went back to medical school.
Mm-hmm.
And how would you differentiate those two, CRNA versus sort of a MD anesthesiologist?
In a very similar situation, kind of like a parallel to a PA and a physician. I think that the anesthesiologist bears the ultimate responsibility if something happens to that patient while they're under anesthesia. Mm-hmm. The nurse anesthetist, CRNA, is available to perform the duty, and they carry obviously responsibility, but they don't have the ultimate liability.
Yeah, and I think one thing that patients don't understand, that when I utilize a CRNA and there's no supervising anesthesiologist in the building, I bear the brunt and the responsibility and the liability for that anesthesia. And so one of the things that was mentioned by this blog is and I really love this analogy. The blog writer kind of writes that as a CRNA, or maybe we can translate this to PAs, it's like being a highly skilled pilot. Excuse me. Mm-hmm. And that pilot can be very, very talented, can know the airplane they fly inside and out, has trained on the simulator, knows how to fly their 737. That's the plane they fly, right? Mm-hmm. They don't fly another plane, right? Mm-hmm. Or they have to train on that plane. And they can handle the takeoff, the landing. They're responsible for the people that are on that plane. And you want a very good pilot. That's not a problem, right? Mm-hmm. But the anesthesiologist, or in this case, the MD physician, is an aeronautical engineer. Mm-hmm. They are someone who knows the physics of how airplanes fly, and they are themselves a pilot. They know how to fly the planes, but they are experienced enough in aeronautical engineering that it's not about just flying the 737. They can fly a 787. They could fly a Cessna. They understand how the wheels work and how the brakes work and how the engine works, and can take apart the engine and rebuild it. And it really is a global understanding, right? And so when I say I can supervise or manage a CRNA in my office, it's because I am willing to say, I understand the physiology of what is happening to that patient under my surgery, and I can take care of them in an emergency. Mm-hmm. And if I don't feel comfortable, then I don't operate on that patient, or I don't take them to that environment. I have them go where the engine is going to be observed by another person. Would you say you like that analogy for your own profession?
Yes, I think so. I mean, listen, there's always caveats to things. I think that there are some, just like in my profession and in your profession, there are some really bad doctors and there's some really bad PAs.
Oh, sure. There's bad aeronautical engineers. There's bad pilots. Okay, so
right. But I think I like that. Mm-hmm. I think on my first rotation as a PA student back in 2008, it was general surgery, and the supervisor, he was obviously a surgeon, and he said to me, Kristen, you can train a monkey to do surgery.
That's
it's
correct.
Really not that hard. He's like, the thing that makes it challenging is that you know what to do when something goes wrong,
That's correct.
And what you need to know to do. And I remember that, and I think that this kind of applies.
Yes, it applies. So and I don't know how much people are I don't know that much about the airline industry. I'm not a pilot, right? But for example, like when there's a problem, let's say that there's a problem on the airplane and it's not in the checklist, or the pilots do their checklist. They call in. They actually call in to home base. They call in to Boeing or whatever, and Boeing finds them an aeronautical engineer, the engineer of that aircraft, to talk about the problem with them. So even in the airline industry, it's a very similar system to healthcare, because lives are on the line. So if you are doing something, you're treating something, you're doing surgery, and there's a problem, I'm there, right? And I think that that's one of the strange things that is this kind of cognitive dissonance for patients, right? I'm a board-certified plastic surgeon. Board-certified plastic surgeons, it's one of the most competitive specialties in America, which means that we are some of the smartest doctors to graduate medical school. We undergo residency for just as much time as heart surgeons and neurosurgeons. I know an incalculable depth about human physiology, about anatomy, about pharmaceuticals, about pharmacology, and there is an attack in this country on physicians and the knowledge that physicians have. Again, maybe a couple of bad apples ruin the bunch, but essentially this complete sort of demoralization and devaluation of the training and effort that goes into doing that. But that is exactly what happens in the air. That's exactly what happens on the ground. And so people go and they want to get from A to Z. They want to just get, they don't care who the aeronautical engineer is, right? Until your plane has a problem. And then you're really worried what your aeronautical engineer is. And most of the time, the plane won't have a problem. And so the question is, from me to you, is there value in still having physicians in this country?
What a question. I think so. I mean, I think that not only have physicians been kind of devalued, I think, again, it's the rise of social media and TikTok videos, and everyone thinks that they did their research because they watched something on TikTok, you know. But that happens to us too. And yeah, my level of training is not anywhere close to yours. But I absolutely think there's a place for physicians. I do.
Yeah.
Yeah.
I mean, you know how much I value physician assistants or associates in my practice and the kind of vision I have for you guys in the process, right? And, you know, we do these incredibly complex surgeries that most plastic surgeons, whether board certified or not, cannot pull off. And they cannot pull them off alone. And so we are able to do incredibly complex surgeries, some of the most difficult things like thigh lifts, brachioplasties, things that other plastic surgeons avoid. We do them safely. We do them within very low, below industry standard complication averages. And we combine them with our surgeries because of this partnership that I have. I can't do it without you, right? I cannot fly the plane without you. Just like, to a certain extent, if there's a problem, you need that aeronautical engineer to like guide you on it, you know?
Yeah.
But the reason I ask this is that, you know, you have this problem, right? And I'll quote here: by 2036, the American Medical College estimates the U.S. could face a shortage of somewhere around 80,000 to 100,000 physicians, particularly primary care doctors in short supply, from 20,000 to 40,000, and surgical specialties could see up to 20,000 shortfalls in the same period. And some expect even higher, over 100,000 shortage in physicians. And I think that there's several drivers of shortage, right? You have an aging population, you have older physician retirements, and you have attrition for the practice. Doctors are leaving clinical practice mainly because of rising costs of doing business, the commoditization of healthcare. You have, private equity squeezing physicians, and this belief, again, from the general public that physicians are no longer valuable in the decision-making process, whether they think it or not. That is dying because, again, people are willing to take just as much medical advice from a TikTok video than they are from their physician. And so do you think that physician assistants are the right, and or even let's call them nurse practitioners, are the right people to sort of fill in this gap and fill in this role?
I mean, that's why the whole physician assistant I can't speak about nurse practitioners, but the whole physician assistant profession was started, I think it was started in the Navy, but really when I went to school in 2007, they were training us as primary care providers. That was our education, because we were meant to go out there and fill the gap in these rural, low income areas to fill the primary care gap, right? So that was almost 20 years ago. The problem is that when you leave PA school, and it's really to a much lesser degree than medical school, but you have student loans. And I would say I graduated PA school with, I think, 47 or 48 people in my class. Probably 10%, 15% went into primary care. There was the compensation is poor. Like, people don't want to move to those areas, right? You pick a surgical subspecialty, something more exciting, you get to do more, like all this stuff. So, I think that's what they were intended to do. And many people do it quite well, but there's a problem because nobody wants to actually go do primary care.
Sure.
Right.
There's a financial problem and that's the same thing that you're seeing. It's just history repeating itself because that's what happened in the physician world too, right? Again, in 2024, 43% of physicians owe debt more than $250,000 from medical school. And that's just when you graduate from medical school. So again, to give the audience a taste into my own personal finances, my wife and I both graduated with around $250,000 in medical school debt that included almost $120,000 of scholarships that we each got. So me and my wife owe $500,000 just graduating from medical school, not counting undergrad. We then took a path to complex surgical specialties. So it took us 7 to 10 years making minimum payments on those loans where the interest rates exceeded the ability for us to pay and live on what is essentially lower than minimum wage, right? We work 80 to 100 hours a week at probably somewhere around $3 to $5 an hour. To be able to make it through that. And all the while, that loan is compounding interest. So when we finished our training programs, we owed about $1.2 million in debt. And so you have this issue where, I'm 5 years in true practice in this state, and I still owe more than half of my total debt. And you can only do so much while you try to grow a practice, invest in the practice, invest in your employees. And so what you have is that physicians don't even want their children to go into healthcare anymore. We're killing off the physician specialty. But the problem is that now someone got to get their money somewhere. And so now they're going to PAs and nurses to make them into these rapid mill programs that are doing the same exact thing.
I mean, funny story about your medical school debt. There was a brief moment. I probably had been working for about 3 or 4 years, and I thought I needed to go back to medical school. I thought I could do it better than other people, and I really wanted to do it. And I remember I went out to dinner with my dad, and he talked to me about the money I was making at that time as a PA. I had a nice salary. I was working in a surgical subspecialty, and he talked about the opportunity cost of losing that money, compounding over 8, 9, 10 years, and then adding on the student loan after that. And he made it very easy decision for me. If you decide to do this, you're going to put yourself back by 20 years and probably $1 million.
That's correct.
And so he just made it so easy to see. Yeah.
But there is, and what we do and why we do it is, yes, we want to care for people, but there is this delayed gratification process where, and I'm sure the angry TikTok messages will come in about how I make a ton of money, which I don't. Again, most of my money goes back to this practice. But one of the big issues is that debt is a huge burden on people, and I took it, and I'm going to pay it back. And it just goes into every decision you make, right?
It does. And I probably want to say it wasn't all about the financial decision. To me, that's not why people go be physicians, but that's a huge deciding factor.
But it influences a lot of what's going on, right? I'm 40, right? I don't own a home. I'm driving the same car I've had for 7 years. I can't qualify for loans and things because I have this massive debt. And so it's a really difficult equation for people. And that's why you see this shortage of physicians, because you're not seeing physicians go into medical school. You're not seeing them go into primary care specialties. And so the system has to recalibrate. And so the system is recalibrating with mid-level individuals. Meanwhile, everyone is well, the physicians are driving up healthcare costs. Again, physicians account for only about 5 to 8% of the total U.S. healthcare expenditures. But healthcare continues to rise, reaching over $5 trillion, 20% of U.S. GDP. Most of it, administrative costs, overhead, compliance, consume about 25% of healthcare spending. Okay, and so, and then that's not to count the insurance cut that people take. Right, insurance premiums are up to $26,000 per year per family, and that's if you use private insurance. That has risen approximately what is it here now? About 26% rose in 2026. Employer plans rising 10%. This is all the insurance scam, okay?
Sure.
It's just a scam.
Well, you were saying about one thing I want to say is that if I go to a big health system and I see a physician or I see a PA, I'm not paying any less money.
Mm-hmm.
You know, like I get my explanation of benefits and I saw the PA, which, you know, I'm a very big proponent of PAs. Let me just put that out there. But when I get my bill, it's for the physician, right? So it's not like I'm paying any less money even though I saw a PA, you know?
Like, so the physician is the one who bills and the physician is the one who charges for their time, even though you didn't necessarily receive that service. That's again, a kind of controversial topic. Because you're an extender of my work. You're not an associate, which is part of the problem with the word,
the title,
right?
Yeah.
If you're an associate, then you're billing for your own time, and the question is what you bill for that time. And then, right, you're at this entire conglomerate of healthcare, and people want to get their money's worth for this $26,000 they're paying a year, right? But the reality is that if they paid cash for their care, it wouldn't total $26,000 per year.
No.
It just wouldn't.
Yeah, way less.
Right? It wouldn't.
Yeah.
But physicians are part of the problem. PAs are part of the problem. Most physicians don't have a clue what something costs.
No.
They don't know how much their x-ray they've ordered costs. They don't know how much their MRI costs. You know who knows? Me, because I run a private practice.
Sure.
And so I know exactly how much each suture I use costs, exactly how much each gown costs, and I make sure that healthcare expenditures remain reasonable while still delivering excellent quality care. And that has just been completely lost when you have private equity running, I think, what is it now, 32% of hospitals or something like that?
Yeah, I'm not surprised.
Yeah.
Yeah.
And so, you know, and so these physicians these private equity groups can, of course, take a physician who is straddled with debt, who may have wanted to go into primary care, who may have wanted to go into something else, but they have $1 million they have to pay off. And they go, here, I'll sign you up. I'll pay you all this money. I'll put you in a non-compete and lock you into this contract for 5-7 years. And then I am going to put 8 PAs under you who are going to really bill what is essentially sort of shadow service, because we're going to bill at physician rates to the insurance while we make all the money. And the PAs are putting in all the labor and being exploited, and the physician is taking on all the liability. So when one of those 8 PAs makes a mistake, people make mistakes, that's going to happen, and then there's a lawsuit, the lawsuit goes to the physician. The physician's the one who bears the brunt of the lawsuit, who has their malpractice go up, who loses their license.
Now, ours will also go up.
Sure.
But it's a fraction.
It's a fraction of the process.
Yeah.
And so at the end of the day, right, there's this weight that is borne by the system, and its reality is that you just have this sort of like rapidly collapsing system, and it feels like we don't really have a solution, do we?
I don't think so.
Yeah.
I mean, I think unless you really get to the bottom of why healthcare is broken, you're never going to be able to solve this either. It doesn't matter what name you call who, it's not going to change anything.
And that is exactly what I feel is happening in these New York Times articles. You essentially have physicians attacking physicians. You have physicians attacking physicians' assistants or associates, and assistants attacking nurse practitioners, and nurse practitioners attacking nurses. And the whole system just keeps pointing fingers at each other so that we attack each other and forget that the big bad is not the people taking care of trying to help you.
Yeah.
The big bad is an industry that continues to deny healthcare at record rates.
Sure.
Again, 25 to 40% of all medical claims, again, prescribed things by healthcare practitioners who went to school and studied, are denied every year. Okay? And I'm sure everyone on this podcast who's listening has seen this happen to them. A medication they need, their generic is swapped, a test that they have to jump through hoops for. Yeah. The business of medicine in this country is denial of care. That is how money is generated, and that is what has happened. And until that changes, nothing else will. And it reminds me of this, this review, this very nice review I got from a person, but it's like, I know that Dr. Davila is getting the money. Who is supposed to get the money? Like, I'm the one providing the service. It feels like this company should be the one getting the money.
Yeah.
It shouldn't be like some administrator of your healthcare benefits who's telling you you're not allowed to get the thing.
Yeah.
That's a weird one to get the money, right?
Yeah.
I paid $26,000 for my premium. Guess what? You don't get anything.
Yeah.
Please jump through 5 more hoops and do another trick before I give you the coverage. I mean, so yeah, I just think these articles, I don't know who lobbies the New York Times to write these articles, but it's just meant to like make us be rile us up at each other. And the physician groups have to work together. Like what I mean by physician groups, everyone.
Absolutely.
The healthcare professionals need to work together here. That we're not the enemy.
Yeah, agreed.
So
well said.
Okay, well, that was a spicy episode a little bit for me. So
loved it.
Thank everyone for joining. That got a little in the weeds, but we'll be back with a little more plastic surgery and business next time. So thanks for joining us, and everyone have a nice weekend.